Welcome to the International Menopause Society webinar. And this webinar has been supported by an unrestricted educational grant from Bessin Healthcare. Bessin has had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speakers' presentations. My name is Wendy Wolfman. I'm a professor in the Department of Obstetrics and Gynecology and director of the Menopause and Premature Ovarian Insufficiency units at Mount Sinai Hospital in Toronto, Canada, which today we have an absolutely gorgeous, almost fall day. So I welcome all our participants from all over the world and thank you very much for coming. We decided today to change the format. So today, first of all, I will be introducing our speakers, Professor Peter Schnatz and Dr. Michelle Jacobson. Then we will move on to an interesting case that Peter will present and discuss. We will subsequently have a banter amongst the three of us about how to manage that conundrum. And then we will open the floor for some questions and answers or comments with help from you, since some of these clinical areas have no correct answers. After about a half hour, I will introduce, and Dr. Michelle Jacobson will introduce her case, and then she will discuss it. And then similarly, we will have some banter and participation from the floor. If we have time, we may have a third case. But basically, if you would submit your comments through the question and answer portal. I will introduce Dr. Schnatz. He's an associate chairman and residency program director in the Department of Obstetrics and Gynecology at the Reading Hospital in Pennsylvania, where he also served as interim chair from 2014 to 2015. He is currently a professor at Drexel University in Philadelphia. He's the past president of the North American Menopause Society, now called the Menopause Society, and the Philadelphia OBGYN Society. He currently serves with me on the educational committee. He's chair of the educational committee for the International Menopause Society. He was elected as a fellow in the American Gynecologic and Obstetrical Society in 2021, and he is the founder, chairman of the board, and CEO of Faith Care Incorporated, an organization involved in humanitarian aid, both locally and internationally. Dr. Michelle Jacobson, who I know extremely well and I'm so proud of, is a fantastic, brilliant menopause specialist at Women's College Hospital in Toronto and Mount Sinai Hospital, where she directs the Familial Ovarian Cancer Clinic. She did her residency at McMaster University and fellowship in menopause with me at the University of Toronto, followed by a Master's of Health Science in Translational Research. She's the creator and director of the Society of OBGYN of Canada's Community of Practice in Hereditary Breast and Ovarian Cancer, and the primary author of the guidelines on the gynecological management of hereditary breast and ovarian cancer and breast cancer and menopause. And I know that she has presented at the American College of Obstetricians and Gynecologists, and she speaks throughout Canada. So thank you both so much for participating today. Peter, go ahead.
Absolutely. Thank you so much for the wonderful introduction. You seeing me all right? Okay, great.
Yes, it's fine.
All right, wonderful. Well, thanks everybody for joining us. And I'm going to read through the case. This is a fascinating case, and certainly, as the title implies, a clinical climacteric conundrum. This is a 54-year-old G2P2 who weighs 102 kilograms. Her hemoglobin A1C is 63 millimoles per mole, which is 8.9%. And she has severe hot flashes that occur multiple times a day, up to 7 times a day. Her last period was 4 years ago, and she feels constantly hot. She becomes flushed and visibly sweaty. She walks around with a fan She awakens 2 times per night with flashes and feels exhausted. She's tried increasing doses of patches up to 125 micrograms with no efficacy. And she's also tried oral Premarin up to 1.25 milligrams with no benefit. Gabapentin at 300 milligrams TID made her drowsy. And she's also on Zoloft for anxiety. She's a non-smoker and drinks 2 glasses of wine nightly. And now we're going to discuss the management of this patient. So I'm going to just kind of talk a little bit about the patient in general, go through a couple slides to give us some background and just to kind of kick things off here, and then open it up for discussion and questions and so forth. But, this is a really challenging patient. And, when you look at this type of scenario, the first thing that jumps out at you is, what's going on here? Is this menopausal symptoms, first of all? Because we're throwing at her 1.25 milligrams of Premarin without any benefit, and multiple other trials of things. So that's certainly one thing. I want to point out a couple things here that that you want to, at least that I'm kind of go through my mind in terms of looking at this, is, first of all, what's the timing of these vasomotor symptoms? Are these new? Are they unchanged? Or were they there and treated and well controlled, and now at age 54 they're worsening? Because these are things that are going to help you think about maybe what's going on. Is it something that's changed and she has a new diagnosis underlying her menopausal symptoms, or is it not menopause to begin with? Does she have any other symptoms? Vaginal bleeding. We heard a little bit about her sleep disturbances, but sexual dysfunction, vaginal dryness, her relationship status, her mood status. One of these type of patients, in my experience, are not that common, where if it's truly menopause symptoms, you go up high enough on the estradiol dose and you see no response. Mood symptomatology, depression, psychiatric disturbances are one thing I've found that can be more common in these scenarios for whatever reason. She already is on a mood stabilizer, but that's certainly something to think about. And would also consider, I don't usually recommend needing to do estradiol levels, but this may be a scenario where we would think about that. Is there a challenge with absorption? Is she not taking the medication? Something along those lines. Her weight is certainly an issue, and I'll mention in a few minutes the issue of weight and how weight can affect vasomotor symptomatology. Substance use, because a lot of times when patients come to us and say, "Doc, I'm having vasomotor symptoms," they've heard their friends talking about vasomotor symptoms. They're having a symptomatology that they're using that word, but we have to be careful. Is it truly the same vasomotor symptom? Substance abuse disorders and withdrawal symptomatology can often mimic the symptoms of sympathomimetic symptomatology and sweating and so forth. And she has the alcohol in there, certainly not a large amount of alcohol, but we know that many times patients may not be forthcoming with what their actual experience is with their substance use. Prior attempted therapies. So we looked a little bit at some of the medications she's used. Has she tried any conservative approaches or therapies? And what are her expectations? What's the most bothersome things to her, not just with the vasomotor symptoms, but any of the other menopausal symptomatology? So in terms of, is this menopause? And this slide just, points out that there are multiple factors that are in your differential diagnosis when you're thinking about hot flashes, sweating, flushing, flashing in the menopausal age patient. Thyroid obviously comes to mind as a big one. Parathyroid can overlap. Leukemia, malaria with night sweats, carcinoid syndrome, systemic mast cell disease, pheochromocytoma. So obviously, as we're talking to the patient and examining her, we're going to want to know her vital signs and her weight. Has it changed? Does she have any other symptoms of nausea, vomiting, diarrhea? Medullary carcinoma of the thyroid, pancreatic islet cell tumors, renal cell carcinoma. A lot of different things can relate to and cause flushing, neurological flushing, emotional flushing, spinal cord, or reaction, again, as we mentioned, to withdrawal from alcohol or different drugs. And then certain things related to food additives or eating disorders. So, let's move on. Let's assume that, and we're going to come back to what we're going to do specifically in this scenario. But if we've looked at some of these other causes and we are thinking that this is vasomotor symptoms, there are tons of things out there, as I'm sure you've all aware of in the literature, in terms of lifestyle and conservative approaches. I'm a little skeptical as we come into treating this patient that some of these are going to be the cure-all, but certainly we don't want to ignore them or the opportunity to offer these, because they are conservative. Cognitive behavioral therapy, clinical hypnosis, weight loss, I mentioned earlier, is that we used to think that obesity was a protective factor for vasomotor symptomatology. We actually realize now that obesity is a risk factor for vasomotor symptomatology, and we think it has to do with the thermoregulatory process and the adipose tissue acting as an insulator and affecting that ability to monitor and regulate the thermoregulatory zone. Pace respirations, supplements, herbs. We all have patients that come in with the laundry list of black cohosh and St. John's herbals and all kinds of different products. Cooling techniques, triggers, exercise, yoga, mindfulness-based interventions, relaxation, surexcitant, soy foods and extracts, soy metabolite equal, cannabinoids, acupuncture, calibration of the neural oscillators, chiropractic interventions, and dietary modifications. Now, this list, again, is huge, but what's important to point out here, in the recent position statement put out by NAMS, there's a nice review that goes through all of these different options, and really the only three that are currently recommended among these are the cognitive behavioral therapy, clinical hypnosis, and weight loss. A lot of different data out there, but not great data on many of these other things. Obviously, soy, is a phytoestrogen, and so there's different ways that can be looked at, and we can talk a little bit more about that as we move forward. But there is data here, and again, the weight loss in this particular patient, being that she is most likely on the overweight side, unless she's taller than 6'1". We didn't get her height. She would meet the criteria of having a BMI in the obese range. Then as we move into therapeutic options, these are a list of the options that are out there: SSRIs, SNRIs, gabapentin, oxybutynin, fezolinetant, stellate ganglion block, clonidine, pregabalin. Again, and I'm not going to spend too much time here. I do want to point out a couple of these, but then I want to move us through quickly so we can get to some discussion. These are the current agents that have recommendation to having benefit. It is important to point out that none of the interventions are as effective or more effective than hormonal therapy. So in the patient where hormonal therapy is effective and a good option, that should be our first line. But again, in this case where she's not responding and we may want to think about other approaches, we can think about the other agents that have FDA approval. I did want to point out, I notice here on this slide that I pointed out that clonidine is not recommended. Although, there is effect of clonidine, and in the past it had been used quite a bit more. It's certainly not a first-line go-to. But it does have, as a centrally acting alpha-2 agonist, as you know, it's indication for antihypertension. But there is effect on blunting some of the symptomatology that would come along with vasomotor symptoms and withdrawal symptoms and those type of things. It does have some side effects: dry mouth, insomnia, drowsiness. Usually start at a 0.1 and then increase every couple weeks. It does also lose its effectiveness over time. And so what I've seen can be effective with this is using it intermittently, using it for a period of time, taking holidays from it, or using it intermittently when patients have particular need. So this could be, something that we want to think about in this patient as a unique option given her unique situation. Gabapentin, an aminobutyric acid analog, as you know, it's an anticonvulsant, but it's also been shown to reduce vasomotor symptoms. There's several studies out there. 900 milligrams a day is a common dose. It's shown 45% reduction in hot flash frequency and 54% in severity of symptoms. There are also some lower doses that have been utilized. You can use up to 2,400 milligrams per day, but usually starting lower. There hasn't been really good evidence showing a dose response. And so it really seems to make more sense to start low dose. And as we saw in this patient, symptoms were bothersome. We didn't really know if it was effective. We just heard that she got tired with it. So could we try a lower dose in her, and that may be equally as effective. Common side effects: dizziness, somnolence, peripheral edema. Patients, when use gabapentin SSRIs or SNRIs, venlafaxine seems to have a better side effect profile, and patients seem to be more in favor of that in terms of a non-hormonal option. Couple additional prescription therapies. Many of the non-hormone prescription therapies have been evaluated and found to significantly reduce vasomotor symptoms in symptomatic postmenopausal women. You know that paroxetine at 7.5 milligrams and fezolinetant at 45 are the only current FDA approved specifically for vasomotor symptoms. Some of the other FDA approved medicines are not approved for vasomotor symptoms, although they are FDA approved. Other medicines that reduce, as we pointed out, SSRIs, SNRIs, gabapentin, oxybutynin. Suvorexant, it's intended for a sleep agent. There have been some studies showing a decrease in vasomotor symptoms at nighttime, but really was not effective in these studies in daytime vasomotor symptoms, and therefore is not standard of care or recommended. Fezolinetant, is a neurokinin B antagonist and one of the newest agents that is now FDA approved. It's a non-hormonal therapeutic agent, works on the KNDy neurons, and is developed for management of vasomotor symptomatology. And so exciting that we have this new option, and this could be something that we would think about trying after we work through some of these other considerations. A couple of final points here. SSRIs, SNRIs are associated with mild to moderate improvements in symptoms. Gabapentin also improvements in vasomotor frequency and severity. Pregabalin is not recommended due to the adverse effects and some of the controlled substance prescribing restrictions. Because of the significant adverse effects and no recent studies showing greater benefit, clonidine is not recommended, as I pointed out, but can be used in certain situations, and this could be one of those. Oxybutynin has been shown to reduce moderate to severe vasomotor symptoms, although in older adults, long-term use may be associated with cognitive decline. Again, the sleep agent is not standard or recommended, and we have the neurokinin B antagonists that have now received FDA approval. So this is a summary of the medications that we mentioned. I will just leave this up here as we kind of move into some discussion.
Okay, that's great. Thank you so much, Peter. I have a few questions and comments. First of all, we didn't mention at all in the case the use of a progestin if she still has her uterus. Do you think that progestins can add to the efficacy, or with certain types of progestins hinder the efficacy? And
Yeah.
do you know the data, any data about when you add progestins, is the efficacy of the medication improved for hormone therapy?
Yes, I mean, there's certainly data showing that progestins can be effective and can be used for vasomotor symptoms. The problem is that usually the dose of using progestin as the main treatment agent is that you have to give a higher dose, and there's often other symptoms that come along with that that make it prohibitive. In terms of combination with, I'm not familiar with great data showing how that's going to affect the efficacy, apart from data showing that progestins are effective and can be effective. So, I think in this scenario, you could kind of go one of two approaches: is try to manipulate the progestin. I think we've tried a fairly good dose of conjugated equine estrogen. You could go a little higher, maybe a 0.9 BID, but I'm not sure that that's going to do much. You could try it. And again, as I mentioned, you might think about measuring serum estradiol, or even thinking about a trial of a oral contraceptive, because as you know, is that the potency and the androgenicity of some of the estradiols in the contraceptive pills may be different.
Just one little clinical tip. When patients are on Premarin, if you measure estradiol, that's not the biggest estrogen. The biggest estrogen is estrone. And so you might not get big elevations, you probably won't, in estradiol level. And I've had patients refer to me who had they were looking at measuring their estradiol rather than the efficacy of the medication. They kept pumping up the Premarin and the estradiol wasn't responding. So remember that those measurements are good for compounds that contain primarily or only estradiol. There was a comment, and I also had this in the question. SSRIs and SNRIs paradoxically at higher doses increase sweating. Can you comment on that?
Say that again. SSRIs and SNRIs at high
Yeah, if
doses.
you look at the product monograph, it says they may cause sweating. So we use them, we recommend them for therapy, but do you think in some patients they may actually increase sweating?
Yeah, and that's, I think, one of the conundrums with the medication, and probably part of why it's not at this point FDA approved. And I think it's also why when I use an SSRI, always start at a very low dose. Is that because I've found that if it's going to work, it's usually the low dose that is what does the trick, and rarely pushing it to higher doses, and that's when you start to see the other symptoms. So it's almost like you have this seesaw effect of, you want just a little bit, and if you go too much, then you start getting the side effects, which can be troublesome.
Yeah, one patient, and I agree with this, in this patient who's got a high BMI, hypertension, probably oral contraceptives wouldn't be the best option, but a transdermal, which she was on, would probably be better. But I mean, certainly if a patient's desperate.
Yeah. I mean, I think is that, she's not a smoker, and she's young and she's healthy. We don't have any evidence of coronary artery disease. Is it the best? Would it be your first line agent in someone coming in? Probably not. But if you have desperate patient, then it's something that could be considered.
Right. So have you seen this, Peter? That there seems to be some patients who don't, and you mentioned this, don't absorb estradiol. And I don't know, this has to be looked at, but I've seen some people who have had tummy tuck, and whether the fat is removed and you put the patch in the lower abdomen, they don't seem to absorb
Yeah.
the patch. I've never read anything about that, but I
Yeah.
definitely have seen some patients who have continual symptoms, and yet you measure their estradiol level and it remains low.
Yeah.
I'm not sure if this is a genetic thing, if it's an absorption problem. You check, one thing we want to mention, and you mentioned it, Peter, is checking the patch site, making
Yeah.
sure it's not falling off. I've had patients put Band-Aids on top of their patches.
Right.
I've had them put the patches in all sorts of weird places on their shoulder, which is not the best place. Should be on the lower abdomen or buttock. So I think measuring estradiol levels is very helpful. And can you comment on that at all? Have you had patients where the estradiol level doesn't go up?
Yeah, I think and your point is a good one in terms of measuring. Is that you want to make sure you're measuring what you're going to pick up in terms of what the patient's taking. If you're taking estradiol, or switching then to something that you can more easily monitor. Thinking about absorption, even these are the kind of cases where unusual circumstances, you think about things like rare things. So malaria, night sweats with malaria. Is this patient from an endemic area where she's been exposed to malaria or the leukemia? And, these aren't common, but when you're in a situation like this where you're trying everything, is it a patient who's malingering and just not taking the medication or not putting the patch on for some reason? And so these kind of cases, you want to start thinking about the rarer situations of why such a high dose of estrogen is not working for her.
Yeah, I've had patients also switch the patch more often, whether they metabolize it quicker than the 3.5 days. I don't think there's anything wrong with that.
Yeah.
Actually, there's a very good comment also. Um, Phyllis Bronson says, as a biochemist and progesterone researcher, we have had many women get great relief with anxiety from actual progesterone, which converts to allopregnanolone, which progestins do not. And this greatly helps the anxiety. If not vasomotor symptoms, enough must be used for various biochemical reasons. So that's very interesting. In
Yeah.
general, we do tend to use progesterone, but I have to say I haven't bumped it up beyond 200, or sometimes with higher doses of estrogen, I do use 300 of progesterone to
Yeah.
prevent growth of the endometrium. But there are some patients who don't tolerate that much progesterone,
Yeah.
also because of the gamma butyric acid effects within the brain.
Yeah.
Michelle, do you have any comments or tips that you'd like to add?
Well, I always have comments and an opinion, so of course. So this is a challenging case. Number one, I think when you have a patient who is so refractory, but with so many medical comorbidities, a lot needs to focus on optimizing her medical health. Her A1C is actually quite high, and I find patients who have unmanaged diabetes to be very difficult to manage from a vasomotor symptom point of view. And I'm maybe a little bit take a hard line approach to this, but if their thyroid is abnormal, if their A1C is abnormal, and really abnormal, especially, I don't even bother trying to optimize their vasomotor symptoms until these other contributing factors are well under control. So I would consider, and I think there's a comment about this as well, blood pressure, especially occult hypertension, to be an issue for this patient because she's got tons of risk factors. I would send her for a 24-hour blood pressure monitor. I would make sure that her diabetes was well controlled before trying. And I would definitely measure her estradiol levels while she was on transdermal therapy to get a sense of whether they were reaching an optimal range Sometimes switching women to oral therapy can help, but you're really out of luck when it comes to measuring. So you lose that objective tool, which isn't commonly used, but is used really in transdermal therapy for women whose symptoms are refractory or don't really make sense for the dose that you're giving them. I do find that the type of progestogen used can impact the effect of the estrogens. And so sometimes switching the progestins is helpful. But I agree with Phyllis Bronson and with you, who said, progesterone is a safer option from a VTE point of view. And this patient with her potentially sedentary lifestyle and obesity is at risk for VTE as well, especially with elevating doses of oral estrogen therapy. The other thing that I would say is, in Canada and in other places across the world, we don't have access to the NK1, NK13 antagonists, but hopefully we will soon. And this would be a patient in whom I would considering either adding it in. Although really my gestalt from this case is I'm worried that these are not truly vasomotor symptoms of menopause and actually more of a cardiac mediated problem.
Would you ever measure estrone? I know I've tried to order it rarely and it takes a very long time here. And what level? I
Yeah.
mean, we don't have normalization of levels. How about you, Peter? Would you do the estrone levels or?
Yeah, I mean, I rarely order levels in general. Is
Right.
that I think it's so rare. But these are and somebody asked a question in there. What level are you looking for? Well, again, the point is when we're treating menopause and menopausal symptoms, you're not treating a level. What we're doing here is trying to see, is she absorbing and is she taking it and that sort of thing. I mean, generally, you're going to look for at least the lower limit of 30 picograms is the lower limit of normal, and estradiol. Yeah, I mean, this would be a weird scenario where maybe you'd think about an estrone level or switching her to, if she's on CEE, saying let's try estradiol, maybe try a BID because of the shorter half-life and see if that makes a difference. So
yeah, and I think there are patients genetically. We know there has been research, I think it's the tachykinins, where these patients do inherit a high risk for the motor symptoms. And so I think there may be a very small group of patients that don't respond,
yeah.
maybe for a different reason, whether they're enzymatic changes or, as I mentioned, these other brain changes that they've inherited.
Right.
But
Yeah.
I'm
The other
really looking
treatment that
forward
I've
to
had,
using. Sorry, Michelle.
I was just going to add that one other treatment that I've had some surprising success with is an S-tetrol containing product. So we only in Canada have S-tetrol currently in a birth control pill, but S-tetrol on its own compared to ethinyl estradiol is less thrombogenic and has a better hepatic profile. So I am more comfortable using it as women get older compared to other E3 contained OCPs. So this is someone in whom I might consider that because the dose of S-tetrol that's available in the birth control pill we have available is the same as the minimum dose that was found to treat vasomotor symptoms.
Yeah.
Does the Mirena work for hot flashes?
I don't think the Mirena is going to treat the hot flashes. I think, that's a good point this person brought up, and I was going to mention that. I think you have kind of two branch points here is first, trying to manipulate the progestin to see if that's going to be helpful. As someone pointed out, it can help with sleep and it can help with the symptoms. But if it's not working, maybe we go the other direction and use a Mirena so that we can eliminate the use of the progestin and focus on which estrogen product, estradiol product, or non-hormonal products, trying the phasolinetant, trying the clonidine for the symptoms approach.
Yeah,
And
I
the
think
other thing I would suggest,
yeah.
oh, sorry, Wendy. I was just going to say this patient is on sertraline. And one option, of course, if you're worried about serotonin syndrome with adding in another SSRI or SNRI, is use a comparison chart and change her SSRI to one that has more evidence for vasomotor symptom management.
Mhm.
Yeah, and the two other things I were going to add is you do get a little bit of systemic absorption with Mirena. It's not completely devoid of any progestin activity.
Mhm.
And the other thing is, I can't remember the reference, but I believe there was a long time ago studies that did show that adding the progestin component did improve flash response compared to estrogen alone. But I
Yeah,
can't remember the reference.
yeah,
So thanks everybody, and thank you so much for your comments. It's amazing how much we can talk about one
yeah,
case.
yeah.
And now I think Michelle's going to go on with her case, and we're going to do the same type of scenario at the end. Thank you.
Thank you. And again, thank you for including me in today's presentation. It's a big honor to present to such an international audience. Today, we're going to speak briefly about menopause management in the breast cancer survivor, and this is a big part of my clinical population. These are my disclosures, and here's our case. So we've got a 48-year-old gravida 2 para 2 whose status post-lumpectomy and chemotherapy for invasive ductal breast carcinoma. She was diagnosed as stage 2 2 years ago with a high-risk Oncotype DX score. She had a BSO included as part of her therapy for reasons that are unclear. She has severe flashes and night sweats. She's unable to have penetrative intercourse. This is causing her a lot of anxiety and distress. How would you manage this patient? So this is a very common scenario. Sometimes by the time we see women, they are already on some sort of a suppressive agent. Sometimes they've had a BSO, whether it was actually indicated as part of their therapy or just seems to be a very pervasive part of management of breast cancer that has sort of controversial or replaceable data. Today, we're going to try and develop an approach to women with breast cancer or at risk for breast cancer, review the evidence on hormone therapy after breast cancer, and discuss options for symptom control, which are very similar to the non-hormonal options that Professor Schnatz went through. This is an issue because more and more women are being diagnosed with breast cancer, but fortunately, more and more women are also surviving. And many of these women are young. They will face many years where they should have had estrogen, but don't anymore, either because they are using some sort of suppressive agent, like a GnRH agonist, or because they've had a oophorectomy. And for estrogen receptor positive cancers in young women, the standard of care is now some sort of chemical or surgical oophorectomy with an aromatase inhibitor or tamoxifen therapy. The 5-year survival for breast cancer is very high, which is excellent, but it means that women are living with symptoms longer, and these symptoms are very difficult to manage. I don't think I need to belabor the risk of breast cancer from menopausal hormone therapy, other than to say that breast cancer is multifactorial and hormone therapy has a very small, if any, role in the development of breast cancer. When it comes to treating women who have had breast cancer for menopausal symptoms, there's been a real paradigm shift over the last 30 years. So if you look at observational studies and you pull some of the old guidelines prior to sort of the year 2000, most of the observational studies were very pro using hormonal therapy after breast cancer. There's a number of reasons why that is, but in general, the thought is that these were younger women who had potentially lower risk of recurrence, disease. They were picked up earlier, and they had less aggressive disease. There's also very little data included in those studies about receptor status and what kind of adjuvant therapy was used. When we look at randomized control trials, which really shifted our approach to menopause management after breast cancer, we found 2 randomized control trials using combination estrogen and progestogen therapy. And we found 1 study using tibolone or Liviol after breast cancer. These are the observational studies, and overall, these studies suggested a decreased recurrence risk for using hormonal therapy after breast cancer diagnosis. So if you were guided by a systematic review that included only these studies, you would be very pro using hormonal therapy in women with breast cancer. But as we know, it's very hard to glean cause and effect data from observational trials, studies. And so looking at RCT data is really our best bet when it comes to understanding the cause and effect here. The 2 largest studies, the best studies that we have performed for combination therapy, were the Habits and the Stockholm studies, which were both done around the same time in Sweden and published in the early 2000s. In both studies, either in the short term or the long term, we showed an increased risk of breast cancer recurrence. So in the HABIT study, this study was stopped early. This study had more progestin regular daily exposure and used norethindrone and estradiol. They showed a 14% increased rate of recurrence compared to women who did not take any hormonal therapy after breast cancer. In the Stockholm study, it was a little bit different. So they showed no increased risk of recurrence short term. But when those data were republished in 2014, after 10 years, they showed that women were more likely to have a contralateral recurrence. And this study used estradiol and cyclic medroxyprogesterone acetate, so had less daily exposure to progestins. I think what's interesting to take away from these is that even though there was an increased risk of recurrence, there wasn't an increased risk of mortality. And the recurrences in the HABIT study were local. They were either in the ipsilateral or contralateral breast, depending on the treatment offered. In Stockholm, the long-term increased risk showed in the contralateral breast as well. So very little increased risk of metastasis, of distant metastasis, and no overall increase in mortality. The Liberate trial looked at using Liviol or Tibolone, which recently became available in Canada a few years ago, but has been available in Europe for many years and is not available in the United States. And they found an increased risk of recurrence in the estrogen receptor positive group, but reassuringly, even though it wasn't quite powered to do so, they didn't see an increased risk of recurrence in the triple negative group. In the other two studies that included both ER positive and triple negative patients, there was still a twice as high risk of recurrence in the triple negative group as there was in the estrogen receptor positive group. I won't belabor the non-hormonal alternatives because we just heard this from Professor Schnatz, but these are the options that we use for women who are suffering from vasomotor symptoms, who have a contraindication to using hormone therapy, and breast cancer in general is considered one of the most absolute contraindications. So I think we can open this up to questions and discussion. I'll remind you about the case of this 48-year-old gravida 2 para 2 who had a lumpectomy. She retains her breasts and she's had a BSO. She's in surgical menopause. She is suffering from her symptoms. And then I wanted to sort of make this even more complicated because these are the kinds of questions that come up all the time. So how would you approach this case the way it is? And how would you approach it differently if she had triple negative breast cancer? Maybe we can talk a bit around the inclusion of whether a bilateral salpingo-oophorectomy is warranted in women who have a breast cancer diagnosis, full stop. What if she were a BRCA mutation carrier, affected or unaffected, mastectomy or no mastectomy? And some of the really challenging cases that I find in my clinic are women who had a diagnosis of DCIS, so pre-invasive or stage 0 disease, many, many years ago. Perhaps they were treated with mastectomy, or perhaps they were treated with lumpectomy and radiation. A pre-invasive disease treated with a mastectomy should have an incredibly low risk of recurrence, and we have very little data on whether it's safe to offer these women menopausal hormone therapy. But theoretically, if their risk of recurrence is extremely low, this should be relatively safe. What if this patient demands menopausal hormone therapy regardless of the risk? At what point does her autonomy and her quality of life play into your decision making? And what if her primary symptoms are GSM related? There's a whole body of literature surrounding the treatment of GSM symptoms in women who are breast cancer survivors. In general, we think of these treatments as being safe, whether it's local estrogen being used. In Europe, with ospemifene, you have an indication to offer ospemifene to women who have a history of estrogen receptor positive breast cancer if they are remote from their treatment and they have completed their aromatase inhibitor or tamoxifen therapy. In Canada, those women are excluded from the on-label use, but we certainly can prescribe it off-label. And we also have access to prosterone now, which is vaginal DHEA, which doesn't have a black box warning in Canada and has minimal systemic absorption of estradiol and testosterone. What about systemic testosterone? Testosterone has a long history of use with breast cancer as a treatment for metastatic breast cancer and seems to induce breast cancer cell apoptosis when used locally close to the tumor. The IMS position statement on using testosterone precludes the recommendation to use testosterone for hypoactive sexual desire disorder, but says that that's simply because women with breast cancer were excluded from the randomized control trials. So this is, an option to consider as well if you're comfortable to use testosterone, which can help sometimes with vasomotor symptoms, but also certainly with female sexual function. So I'll open it up to discussion with my team here, but my approach to this patient, and I'll go back to the case, would be to consider the non-hormonal options. And if you have access to one of the NK1 or NK1/3 inhibitors, this would be a really good option for a patient who is suffering. And I would absolutely consider using any vaginal estrogen, ospemifene if she's not taking any of the AI or tamoxifen therapies, or progesterone for her vaginal symptoms. And I think one point that is always important to emphasize is that very little attention is paid to compliance with aromatase inhibitor or with tamoxifen therapy, but many women discontinue their aromatase inhibitor because of gynecologic side effects. So if we are afraid to treat vaginal symptoms, and that leads to women going off of their chemotherapy, where the risk of recurrence is so significantly elevated, we're actually doing them a disservice. Because if we can manage their side effects and allow them to stay on the most powerful treatment that will avoid the risk of recurrence, then they'll actually be better off in the long run.
Thanks so much, Michelle. That was so much in such a short time. Maybe could we go back to your discussion areas? Can you put the slide back? Because maybe you could answer some of these.
Yeah, so these are the most complicated scenarios that I think we run into. Triple negative breast cancer is really complicated, and women who have higher rates of triple negative breast cancer tend to be BRCA1 mutation carriers.
Right.
There's a much higher representation of triple negative disease. So these women are often diagnosed younger, and oftentimes they end up having a bilateral salpingo oophorectomy, not as part of their breast cancer treatment. So there is no role for surgical or chemical oophorectomy for the management of their breast cancer recurrence. But they have the BSO because they're also at elevated risk for ovarian cancer. And so their ovaries are removed usually by 35 to reduce risk for ovarian cancer. This leaves us in this clinical conundrum where our patient had her breast cancer diagnosis, it was treated. She was usually returning to cycle because oftentimes women start menstruating again after their chemotherapy. And then at 35 to 40, their ovaries are removed. And now we tell them, because there's an increased risk of breast cancer recurrence with hormone therapy, the hormones you were having 5 minutes ago are no longer safe for you to be exposed to. So this is a very challenging group of women, and hormonal alternatives, because if their primary concern is their risk of recurrence of breast cancer, then offering them non-hormonal therapy is the safest approach. But if they are remote from their breast cancer diagnosis, they were menstruating for the last 5 or 10 years, and now they've had an oophorectomy because of ovarian cancer risk, then there are situations where I consider giving hormonal therapy to these women. And when it comes to a choice of hormonal therapy, I usually give them 3 options. One is to consider using Liviol or Tibolone, because we do have randomized control evidence, even though it wasn't quite powered, that suggests no increased risk of recurrence. The second option is I'll give them continuous transdermal estradiol with cyclic micronized progesterone, because that is the most biochemically similar to what their own ovary was doing until it was surgically removed. And the third option is to consider a medication like the TSEC, Duaviv or Duavi, which contains conjugated estrogen and basidoxifene, because the basidoxifene has data similar to tamoxifen where it can be breast protective. And the conjugated estrogen has that 20-year WHI follow-up data suggesting a lower risk of breast cancer than placebo. So those are the 3 options that I offer triple negative breast cancer survivors if they are set or interested on using hormone therapy. I consider this to be a very gray zone. And really, this is after a long discussion on their primary goals. So if their primary goal is being afraid of breast cancer recurrence or they're high risk, we would go the route of a non-hormonal. But if their primary goal was management of vasomotor symptoms, quality of life, as well as all the other diseases that are more likely to cause mortality as they age, osteoporosis, cardiovascular disease, then I would offer them hormone therapy in that scenario.
So just to go over that, Michelle, you'd give CZA, Premarin, estrogen, and progesterone sequentially. And what was the third option?
Tibolone or Liviol, because of the randomized control evidence that suggests no increased risk of recurrence. This is a very individualized discussion, but sometimes the patients will come from their oncologists knowing that they can't take hormone therapy ever, and that's sort of what's been the discussion. And others will come saying, my oncologist says it's fine because I was estrogen receptor negative. It's not that simple. We know that triple negative breast cancer is overrepresented in women who are pregnant, where estrogen levels are very, very high. And triple negative breast cancer is more common in younger women, usually because of a BRCA1 mutation. So it's not simple, but it's a challenging scenario to treat women. And I really go by their individual choices and their individual risk profile.
Okay, and then can you comment on BRCA carriers, unaffected?
Yeah. So an unaffected BRCA carrier, regardless of whether she's had a mastectomy or not, can be offered menopausal hormone therapy as hormone replacement after her surgical oophorectomy. So we have prospective data looking at over 1,000 women, primarily with older options like conjugated estrogen and medroxyprogesterone acetate, which suggests no increased risk of breast cancer in these women. The women who were able to take estrogen alone, as is very, consistent with the data we have, had less breast cancer than the women who took combined continuous therapy. But either way, there was not an increased risk of breast cancer in these women. I think that's probably twofold. Number one, these women are at incredibly high risk with a relative risk of 200 of developing breast cancer. No amount of hormone therapy, whether it's good, bad, safe, or dangerous, is going to significantly change their clinical risk because it's already baseline very, very high. With women who have had a mastectomy and are unaffected carriers, they should absolutely be offered hormone therapy. And certainly women who have their breasts should still be offered hormone therapy if they've not had breast cancer, but you would consider the breast safest option. When I think of the most breast-friendly hormonal therapy, I think of a pyramid. If the woman is able to take estrogen alone, I tend to favor conjugated estrogen because there is randomized control evidence for less breast cancer. And if they have a uterus, then I would consider using the TSEC, so conjugated estrogen with basidoxifene. I would consider using tibolone, or I would emulate the E3N study, which for the first 5 years showed no increased risk of breast cancer in women who were taking continuous transdermal estradiol with cyclic micronized progesterone.
Okay, and what about DCIS?
DCIS is really, really complicated because we think of this as a pre-invasive disease, but at the same time, if we offer lumpectomy, we also offer as the standard of care radiation therapy. And that to me says that we worry about the risk of recurrence in the margins, and that's why we're offering radiation therapy. I have a low threshold for offering hormonal therapy to young women who have DCIS and were treated with a mastectomy. This is again going to be most commonly in women who have a very high risk of breast cancer recurrence, or with a new breast cancer. So perhaps they're carriers, or they've got strong risk factors, or very dense breasts, or they were very young with high-grade disease when they were diagnosed. For women who have had DCIS but retain their breasts, I'm concerned about risk of recurrence, and that would be someone I'd be less likely to offer hormone therapy to. Although again, this is a very individualized discussion.
Okay, so someone made a comment in stage 4 patients with low life expectancy. Do you not think that a better quality of life using menopausal hormone therapy should be given? The only thing I'm going to say about that, I was recently speaking at the Canadian Breast Cancer Conference, and even stage 4 patients now may have quite a long life expectancy with the therapies they have. And the idea is patients living with their metastatic disease. And so obviously if they're very close to the end of their life, but what would you say about that, Michelle?
Again, I think this is a very personalized discussion. I tend to offer non-hormonal therapies first, but again, I have a very low threshold for offering women who desire quality of life, are understanding and accepting of a potential increased risk of recurrence, hormone therapy. And for somebody with stage 4 disease who by definition is not curative, I think it should be up to them, and I'm very comfortable prescribing in that scenario.
I think one of the key things that you focused on, which I think is so important, is the individualization. And there's so many of these areas where there aren't good randomized control studies to look at, and we really have to know what they want. And the key also is being in discussion with their other providers, their oncologists, and so forth, because that can be a real conundrum when the patient has a certain desire for quality of life that you're trying to maintain, and then they're getting conflicting opinions. So being in touch with the other providers is paramount.
The other
Absolutely.
point that someone made is the interaction between SSRIs and tamoxifen. Michelle, you want to talk about that?
So that's particularly true for paroxetine, which is in the States on label for vasomotor symptom management. So paroxetine and tamoxifen are metabolized by the same enzyme and can interfere with the metabolism of tamoxifen. So I would avoid paroxetine specifically, but not medications like venlafaxine or desvenlafaxine, which are SNRIs and are not metabolized by the same enzymes.
Okay. Another question, what about using aromatase inhibitors with prosterone?
So
Yeah.
we don't have published data yet, but hopefully very soon. There was some poster and abstract data presented at the last IMS conference in Portugal in 2022. We know that prosterone is metabolized into estrogen and testosterone by a pathway that first metabolizes the DHEA to testosterone and then aromatization into estrogen. So women who are taking aromatase inhibitors should have a very low metabolism of testosterone to estrogen. The majority of the DHEA should remain testosterone after its initial metabolism and can still be very beneficial for vaginal and vulvar symptoms because of the significant number of testosterone and androgen receptors in the vulva and vagina. We have nice histology and photographic evidence of women taking aromatase inhibitors and using prosterone, which still show a significant improvement in symptoms. So this would be my treatment of choice for GSM for women who are taking aromatase inhibitors.
Okay, and for someone on tamoxifen?
Shouldn't really matter. Tamoxifen, we don't depend on low levels of estrogen. We think of tamoxifen as competing for the breast estrogen receptor. So you should be able to use any kind of estrogen therapy locally in the vagina in women taking tamoxifen without changing their risk of breast cancer recurrence.
Right, and I think there is some data with respect to that.
Yeah,
there are
the data is so
studies.
conflicting. Yeah, like they're large registry studies. The ones that are sensationalized are often, confusing. Like most recently, the large registry, I think it was Cold, suggested an increased risk of recurrence with vaginal estrogen, but not with systemic and vaginal estrogen. So I always try and take them with a bit of a grain of salt when it comes to registry studies. And as always, we're waiting for large randomized control trials to be our best source of evidence.
And what about prescribing testosterone for women with a history of breast cancer for decreased sexual desire?
So testosterone is shown to be effective for hypoactive sexual desire disorder, but women with breast cancer were not included in the RCTs. That being said, testosterone has been used as a treatment for menopausal symptoms, for hypoactive sexual desire disorder, and for breast cancer treatment, especially in metastatic breast cancer, for many, many years. So this is, again, an area where I would use caution because we don't have specific individualized long-term risk data. But for women who are suffering either from vasomotor symptoms or from hypoactive sexual desire disorder and are willing to take perhaps what is a conjectural risk, I would offer them off-label testosterone with close follow-up if they and their oncologist were in agreement.
Okay, and let's see. Someone suggested prophylactic mastectomy in preventing breast cancer. How effective is prophylactic mastectomy in preventing breast cancer in women on prolonged hormone therapy?
I mean, prophylactic mastectomy is very effective at preventing breast cancer, but hormone therapy, whether it's prolonged or not, does not increase somebody's risk of breast cancer to the amount where a prophylactic mastectomy would be offered as a reasonable option for breast cancer prophylaxis. So I would not recommend that. I've had a prophylactic mastectomy. It is a difficult surgery to recover from. It has somewhat high morbidity, and I think that would be a huge undertaking for prevention when the breast cancer risk from hormone therapy, even prolonged and even with the least breast friendly medications, is not that high.
So I just thought one person sent in something really useful. She said, "It is my belief that as medical professionals, we need to make provision of menopause care far better and more accessible throughout each woman's breast cancer journey. Most women I've seen for advice in this area have never had any information about menopause from anybody. The most valuable skills we give these women are time and validation of their symptoms. Each woman needs an individual approach. Shared decision making is absolutely key, especially as I think it is unlikely we will ever get randomized controlled data on the use of hormone therapy post breast cancer." So I thank you very much. That's Sarah Ball's comment. So I'd like to really thank both Peter and Michelle for a fantastic discussion. And thank you. You can tell you've had a ton of clinical experience, and that adds so much to your comments today. And we have one last slide that we'd like to put up about our IMS international meeting next year, 2024 in Melbourne. So get your tickets now so you can get a good seat on your plane. And we hope to see you there. And I thank IMS and Basan again and our presenters today for our discussion. Thank you very much and have a good day.